If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettle. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Welcome back to the Vitality Collective podcast. In this episode, I'm joined by the brilliant Dr. Dennis Hughes, a renowned expert in internal medicine and longevity. Together, we'll unravel the mysteries of brain health, from understanding the biology of Alzheimer's to actionable ways to enhance cognitive resilience. The key takeaways from this episode include the importance of sleep for brain detox, how exercise protects neurons, and why personalized biomarkers can transform how we age. This is a must listen for anybody aiming to future-proof their brain. Welcome to the Vitality Collective podcast. I'm your host, Dr. Jeremy Bettle, and I'm here today with my good friend, Dr. Dennis Hughes. Dennis, welcome.
Well, thank you for calling me your good friend. Thank you for having me.
Thank you for being a good friend. Let's go right into Alzheimer's. And what exactly are we talking about here? Can you give us a definition of Alzheimer's and if there's any difference with dementia and these other disease states?
Alzheimer's is the most common cause of dementia, makes up about 80% of cases, rough number. And there was a psychiatrist, Dr. Alzheimer, who was seeing a patient named Auguste Dieter. She lived from 1850 to 1906, and she developed premature dementia. And this was the age when we were using microscopes to look at biopsies from people who had passed away. And Dr. Alzheimer saw these amyloid plaques, which are clustered of misfolded beta amyloid, and neurofibrillary tangles, which are tau protein within the neuron. And so for a long time following this, we associated cause and effect between beta amyloid plaque and neurofibrillary tangles as a cause of Alzheimer's dementia, but more recently it's been called into question.
So just break those two things down for me a little bit. What exactly are those two proteins you talked about? So there's tau and there's beta amyloid. Can you give us a definition on those?
Sure. Amyloid is thought to be a foe when we think about neuronal injury and Alzheimer's dementia, but it isn't all foe. It's believed to be important for antimicrobial activity, synaptogenesis, the formation of new synapses between neurons, and possibly also maintaining the blood-brain barrier, which keeps out harmful substances from the brain. But amyloid comes from amyloid precursor protein, APP, and it is thought to be elevated when neurons are inflamed and under stress. So APP is cleaved by an enzyme called beta secretase. And so if you have a mutation in APP that causes it to be cleaved improperly by beta secretase, it may misfold, become insoluble, and form clusters both within the cell and exterior to the cell. And so tau protein is associated with the maintenance of the microtubule network in the neuron. So this is called your cytoskeleton. And the microtubule network is like a highway for substances and organelles. So every neuron has thousands of mitochondria, which is the power plant for the neuron. And the mitochondria are passed down this highway of microtubules. If tau, which maintains the tubules and may compress them when needed, becomes hyperphosphorylated when phosphorus attaches to tau. The tau tangles up that microtubule highway, and the mitochondria are not able to be passed down the long axon. So in a nerve cell, you have the cell body. It looks like an egg. It's got a nucleus. That's where the DNA is. And then you have the axon, which conducts the electrical impulse and ends at a synapse. And so you need those mitochondria to be ferried down the length of the axon. And phosphorylated tau impairs that. And so the problem is with the theory that amyloid causes dementia, when we use modern drugs to decrease the burden of amyloid in your brain, and we can see it disappearing on amyloid PET scans, there doesn't appear to be an improvement in cognition. So either A, we've treated those people too late along the course and they're at the point of no return, or B, amyloid is overproduced during situations that injure your neurons, like oxidative stress, metabolic problems, and so on. So maybe there's no cause and effect between beta amyloid and Alzheimer's dementia. Maybe both dementia and amyloid occur because of those other stresses. So they are associated.
Yeah, that's really fascinating. I've heard you and others refer to amyloid almost as tombstones. So the damage is done, and that's the marker that the damage has been done after the fact.
Yes. So classically, I've always thought of beta amyloid as accumulating outside neurons, but the beta amyloid can also accumulate within the neuron, and maybe it causes cell death and the cell breaks open, releasing the beta amyloid that was within. The beta amyloid 42, as compared to beta amyloid 40, is less soluble. So it could be neuronal stresses that cause overaccumulation of beta amyloid, but there are other things too. The whole thing is so complicated. We sometimes talk about lysosomal dysfunction. Lysosomes are these organelles that are full of enzymes that break down unwanted proteins and other substances. They do your cell's housekeeping. And so if your lysosomes don't work, you become a hoarder. You just build your cells up with junk that doesn't belong there.
Right. And you mentioned a couple of times the solubility of amyloid. What do you mean by that exactly?
Well, one of the theories is that it's the clustering of beta amyloid when it's insoluble that causes the problem. As I said, amyloid is thought to be both friend and foe. And so when you cleave amyloid precursor protein, APP, you end up with various different fractions. You can have 42 or 40 being thought as the more soluble one. Your brain has a system called the glymphatic system that is working during slow wave sleep that purges the brain of beta amyloid and other metabolites. And stage 3, which is the stage right before REM or dream sleep, is the deepest stage of sleep when you're going to have most activity in the glymphatic system. And so Clotho, and we can talk about that in a bit, is thought to aid your brain in purging beta amyloid from the cerebrospinal fluid, the CSF, into your blood and then out.
Yeah, so if it's insoluble, that glymphatic system can't actually transport it out of the brain. And so that's where you get the clustering.
I would think so, because it's going to be difficult to handle it at that point, to pass it through the receptor and into the bloodstream.
Sure. Well, that's a really nice segue for us to actually go into some of those risk factors. I love the fact that we dive right into sleep. Let's go a little deeper there on the sleep as a sort of, it's a cognitive enhancer. I've always described it as the number one performance enhancer known to man from a physical and cognitive perspective. Chronically, and I guess acutely, what are some of the impacts of interrupted or short sleep?
Well, we can see the effect of that immediately on amyloid PET scan. During 2 studies, one of which was performed in 2018 and another one in 2021, they took groups of people after a good night of rest and then after a night of sleep that was impaired. And you can see immediately the increase in beta amyloid after the night of impaired sleep. So I think of sleep as recovery for the brain. Yes, the brain is active during sleep. Unlike the way we thought before, we thought the brain was just kind of on, low level. It's active, yet it's somehow a recovery for your brain. And I think that people who chronically either don't sleep enough hours or have broken sleep, it's like an injury to the brain. And I think that because the neurons are suffering, the beta secretase enzyme activity is increased. You are producing more amyloid. So the amyloid elevation is just showing you the stress on the nerve.
And is that something that sort of goes up and down? So if I have one night of bad sleep, we see this stress, but then if I follow that up with good sleep thereafter, do I recover? Or is that sort of a permanent mark that is then carried forward and compounded?
I think with any disease process, it's the chronicity of injury that causes the chronic disease.
Yeah, so certainly a contributing factor, and really interesting, linking the activity of the glymphatic system during deep sleep and the action of clearing amyloid there. That really gives us a clear picture as to how that mechanism might work.
Or is it that having prolonged deep sleep just allows brain recovery in general, and that's what makes your neurons more healthy and prevents premature aging with cognitive defects? Is it just that the amyloid is showing you that the brain has been injured? I'm not certain. I don't think any neuroscientist will say that we have all the pieces of the puzzle together yet. I think we're putting the puzzle together. It's on the table. Some pieces are put together, and we're still scratching our heads on other parts.
And so what are some of those other parts that we've seen? Because this is obviously such a complex condition. Where are you looking for this early in your patient?
Usually I'm seeing middle-aged or older patients in my practice. So going forward, I'm going to be offering brain markers of neuronal stress to all my patients routinely. So we have tests now, and I use Quest Diagnostics. There's other labs that do them as well. We used to be able to only identify beta amyloid 4240 and phosphorylated tau from a lumbar puncture, which is pretty cumbersome and hazardous. But now we can measure those things accurately from a blood test. And I tell my patients, if your numbers are off, don't be concerned by this in the short term, because I'm just trying to say, okay, here's the stress on you. Let's try and intervene and do whatever we can to limit the stresses on your brain so that you don't suffer and develop cognitive defects as you age, just like any other biomarker.
And what do you think then are some of the other factors that sort of cause that neuronal stress? If we go back sort of into the body now, what are some of the more distal and lifestyle related impacts on the brain?
Okay, we can start with exercise. I think there's nothing better you can do for your body and your brain than to exercise. I can rifle off a couple things that exercise does for your brain that's very favorable. Exercise induces the level of klotho, Klotho, by 2 to 3 times after intense cardio exercise. Klotho is neuroprotective, even if you're building up beta amyloid plaque in your brain. And this has been shown in non-human primates. And there's another called brain-derived neurotrophic factor, which is neuroprotective. It's involved in neurogenesis, and it also causes you to produce more dendrites, which are these little sprouts that connect neurons together. So both of those things are enhanced by exercise. We sit around too much, and we're just not boosting, at least most of us aren't, those as much as we could be. Think of how much we sit now. Even that person that goes to the gym. I went to the gym for 45 minutes today. Well, that's great, and that is helpful. But that person's going to sit at a computer for 8 hours that day doing work. So we're just not moving around as much as people used to.
Yeah, and I think that links to even down to the level of blood flow to the brain. We know when we're in our zone 2 range, and that's 65 to 75% of your max heart rate. So a pretty low level, but that being the way that we actually create the most blood flow. So just going for a walk creates huge amount of blood flow to the brain. And, just from a substrate delivery and energy and waste product clearance, I think that, there's got to be huge benefits to just the amount of movement we do day to day getting that steps in.
And also how exercise improves the health of vessels. So exercise reduces your blood glucose level. It brings you back into energy balance. So there are these channels that are sent from within the cell to the surface of the cell. They're called GLUT4 channels. And so when you exercise more, when you lose weight, you send more GLUT4 channels to your cell membrane, which aids in glucose disposal or the passage of glucose from the blood into the cells. So vascular disease, which is atherosclerosis, limits the blood flow through the microvessels of the brain. Most of the arteries in the brain are microvessels, probably 80-85%. And your brain is a very hungry organ. And the brain has so much demand. When it's not given what it asked for, you have a supply-demand mismatch. And that's when the neurons become inflamed and they degenerate. So whatever you can do to preserve the health of arteries within the brain and, of course, everywhere else would be helpful in preventing cognitive decline down the road.
Yeah, and in our partnership with clients that we've worked with together, offering all of those blood tests for the brain, but then also what I loved was how deep you go into the lipid profile, and something that I learned from you, essentially speaking to that, is what's happening in your heart is happening in your head. What's the importance there? Like, what's the link between those two things?
Well, your arterial system is one system, and whatever affects it here affects it everywhere else. And so most practitioners are ordering lipid panels. And when I say lipid, I'm talking about cholesterol, but also the number of carriers that ship cholesterol through the bloodstream, called ApoB, for one. Most practitioners are ordering very basic panels that are a bit outdated. The newer panels are very easily available through local labs, and the testing is not expensive. No reason not to do them.
Yeah, so we hear that a lot. In fact, Michelle heard this the other day. We don't recommend doing that because insurance won't pay for it. This was pertaining to something else, not lipids. But from our knowledge of sort of proactive medicine, we know to ask that question. If somebody gets met with, okay, ApoB isn't covered by your insurance, how much are we talking here? How much does that cost?
Can be $10 to $15 for an apolipoprotein B test. And just more basically, when I order labs and they're not covered, or if the patient has to pay a lot for them, I hear back from the patient. They're not pleased about it. But I've not seen any insurance reject apolipoprotein B or lipoprotein a as a test. So I order them on everybody.
Yeah. And why wouldn't they be more commonly ordered?
I think it's just the lack of training. In my residency, we didn't talk about apolipoprotein B, although it was discovered in the 1960s. There's this big lag time between a discovery and its use in real clinical practice. It's kind of a frustration of mine. I talk to some of my colleagues and they'll just do this. They'll say, oh, that's not needed. Even though there's ample evidence to say that apolipoprotein B is a much more telling risk factor for vascular disease than LDL cholesterol. Not to say that LDL cholesterol is not important, but LDL cholesterol alone is not as telling as ApoB. So I like to triangulate with multiple tests to look at the same issue so that I feel more confident I haven't missed something.
And so just to give us a review, ApoB and Lp(a) you mentioned, what are the mechanisms of how they are related to atherosclerotic conditions?
In general, cholesterol is needed by the body for functioning. It makes up our cell membranes, and cholesterol is turned into steroid molecules such as cortisol, testosterone, estrogen. Any cell in the body can make cholesterol. So we need it. But our modern way of living, which includes overnutrition, we're living in this little corner of human history when we could eat 3 meals a day and snack before, between, and after. This modern way of living with overnutrition has changed the distribution of the cholesterol carrying particles. So I think a lot of people have it told to them that there are different kinds of cholesterol, like good cholesterol and bad cholesterol. It's an oversimplified, dumbed down way of talking about these things. There's no such thing as different cholesterols. There's only one kind of cholesterol, which is shipped around the blood within lipoproteins, which are these spherical macromolecules. And it's those lipoproteins that are atherogenic that will wedge into the artery lining to initiate a cascade of inflammation and degeneration that causes artery disease. So overnutrition, metabolic disorders like prediabetes and diabetes, it's a spectrum, cause change in the distribution of your LDL, VLDL particles, which carry cholesterol, such that the particles become smaller and more dense. They become more numerous. And because they are more numerous, they, through something called gradient pressure, are more likely to end up in your artery wall. So when you look at a blood panel comparing two different people, they may have the same LDL cholesterol. And to define LDL cholesterol, it is the amount of cholesterol in milligrams carried within all the LDL carriers within a deciliter of blood. So a person A does not have insulin resistance, which is the driver for type 2 diabetes mellitus, and person number B does have insulin resistance. They both may have the same LDL cholesterol level, but the person who has insulin resistance is going to have a change in the distribution of the LDL carrier such that the person with insulin resistance is going to have smaller, denser, more numerous LDL particles. This, through physics called gradient pressure, is going to cause, in the insulin-resistant patient, more of those LDL carriers to end up in the artery lining, where they then will become oxidized and incite a chronic inflammatory destructive process. So this is why doing just LDL cholesterol means you're going blind. Now, I can kind of infer you're going to have a high ApoB anyway if I see that you're insulin resistant. There are other biomarkers that will show me that. A high insulin level, a high triglyceride level, a low HDL cholesterol level, a high VLDL cholesterol level. If I see that, I know you have high ApoB. But I like to look at my numbers so that I can get a baseline and then I can follow after interventions such as better diet and exercise and maybe even medication.
Mm-hmm. Yeah, so that was going to be my next question then. Someone comes to you and they have insulin resistance and they have high ApoB. What do you then do about that?
So for me, it's not either or comparing lifestyle habits and medicine. If that patient is high risk, I'm going to offer therapy. I always tell everybody, look, you're middle-aged here. If you want to enjoy your older years, because atherosclerosis is such a slow process that occurs over decades, you need to get started now. I see sometimes other practitioners are saying, only lifestyle, which is great and it's important. And it's one of the best things you can do to ward off trouble later. But if they're high risk, you should discuss being assertive with lowering ApoB and LDL cholesterol below 60 for each.
Yeah, I think that's such an important point here, is that it isn't either or. What we found in pro sport when we were looking at injuries is that it wasn't, do you need more physical therapy? Do you need to see the nutritionist? Do you need to see the strength coach more? It was that you needed all of them. If everybody on that multidisciplinary team looked at the issue from their perspective and created an intervention, we ended up with these really well-rounded interventions then. And they were really force multipliers on one another in achieving the outcome that we wanted. And the same has to be true here.
I think so. I think if you really want to have your best shot at aging well, you have to go for it.
Yeah. Yeah. And I think just to recap that a little bit. So we're measuring ApoB, we're looking at cholesterol levels to reduce your risk of atherosclerosis, which is going to cause those blockages in the brain, which is going to sort of starve those areas of the brain of nutrients. And so then as we start going down that tack into these different influencing factors, what about the role of body composition? We talked about exercise a little bit. You talked to me previously about different places that body fat is stored in the body, particularly visceral fat.
So visceral fat is dangerous to arteries and your brain and your health in general. So visceral fat, which is the fat that encases your organs, such as within your liver, pancreas, for example, or surrounds the organs, releases cytokines such as tumor necrosis factor alpha, TNF alpha, or IL-1 or IL-6, all of which are pro-inflammatory. When you look at imaging studies, more visceral adipose tissue correlates with a smaller brain. And in fact, when you look at metabolic risks for Alzheimer's dementia, if you have type 2 diabetes mellitus at a younger age, it's not as important if you get it at an elderly age. But if you have type 2 diabetes diagnosed at a younger age and you have the ApoE4 gene, you increase your risk of Alzheimer's dementia by over 5 times.
Wow.
If you have obesity without type 2 diabetes mellitus, you increase your risk of Alzheimer's dementia by 2 times. And there's going to be some play in this depending on when in your life you get these issues.
So can you talk us through the ApoE4 gene and what it means for our risk of developing cognitive decline later in life?
So ApoE, just like beta amyloid, is both friend and foe. When we think about the nervous system, we think about the central nervous system, the brain and spinal cord, and we think about the peripheral nervous system. So when you look at neuron injury in the periphery, let's say you got yourself cut, you'll see that a special type of white blood cell called a macrophage is dumping ApoE in the area. So neurons need phospholipids and cholesterol for cell membrane and formation of the myelin sheath on the axon that increases the speed of conduction of the electrical impulse. And we have ApoE within the brain, which apparently is antimicrobial and also is released when your neurons are under stress. We have at least 3 isoforms of ApoE, and that is type 2, type 3, and type 4. Type 2 is thought to be neuroprotective. Type 3 is thought to be neutral risk when we're talking about ApoE, and ApoE4 is associated with an increased risk of Alzheimer's dementia. You get a copy from mom and a copy from dad. Chris Hemsworth has 2 copies of ApoE4. About 20 to 25% of the population has 1 copy of ApoE4. So ApoE4 is thought to give risk of dementia through various ways. ApoE4 is subject to what's called proteolytic fragmentation, which just means that it can get broken into smaller bits, which cause mitochondrial dysfunction and subsequent release of the 3 pro-inflammatory cytokines, tumor necrosis factor alpha, IL-1, and IL-6, so you get neuroinflammation. It's thought that ApoE4 induces the hyperphosphorylation of tau. Remember, we talked just a bit back, when tau is phosphorylated, it tangles up the microtubules, preventing the mitochondria from being passed down the axon.
And so if we do have these 2 copies of the ApoE4 gene, what does that mean for our risk?
It's not certain. I've heard different roundabout figures. I've heard maybe 8 to 12 times increased risk compared to the general population without it. But I think that we can reduce the risk of cognitive problems associated with having ApoE4. So maybe those increased risk figures will drop in time in those people that are made aware that they have ApoE4 and take the steps to circumvent the potential brain pathology you can get along the line with ApoE4.
I really love that you brought that up. That's something that I'm hugely passionate about. For me, any form of genetic testing that we do, we've historically thought that that was just this immovable sort of risk factor that almost was a death sentence for us. But I think it's so important to view these differently. We must see them as basically signposts for how we then need to conduct ourselves going forward. All of the stuff we've talked about so far are lifestyle factors that impact your susceptibility to developing neurocognitive decline. I think this just highlights the importance of those. If you have that double copy, it just means that all of the other stuff that we've spoken about is much, much more important for you.
I couldn't have said that better. I think that when you have additive risks for dementia, that's where you get into trouble. If you have, for example, ApoE4 and type 2 diabetes mellitus, and you are obese, and you have hypertension and smoking, the risk just keeps climbing. But those people with ApoE4 benefit the most from improved lifestyle habits. And this has been proven in the Chicago Health and Aging Project, which was run from the early 1990s to 2012, where they took 4,000 people and they excluded people with 2 copies of ApoE4. So Chris Hemsworth would not have been allowed in the study. And they also excluded people in the bottom 10% of cognitive tests. And they watched them over the years, comparing the one group that did not adopt the healthy lifestyle habits to the people who adopted multiple healthy lifestyle habits, like no smoking, getting good sleep, exercise, and so on. And you saw a profound difference in the risk of cognitive decline. If you took people with 1 copy of ApoE4 compared to the people that didn't have ApoE4, the people with ApoE4 saw the best improvement over time.
That's really fascinating. And I imagine that it must be really important as well to consider the activities you participate in. I grew up playing rugby. I imagine if you tested early and found out that you have this susceptibility, maybe my choice of sport could have been a little different, where you're avoiding traumatic brain injury.
Sure. And I think that is another argument for doing ApoE4 genotype testing. Because if you're a young person, this isn't just for older people, you may choose not to play football if you have 1 or more copies of the ApoE4 gene. Because that's going to have a greater impact on you should you be injured than in someone who does not have ApoE4.
Yeah, and I think to your point, especially in younger people, with all of these interventions, no matter what we're doing, the emphasis has to be on start early. And that's going to set you up for better outcomes. It's much like we talk about in investing. The best time to start is when on your 18th birthday. The next best time is today, right?
I couldn't agree
those
more.
Compounded effects.
It's kind of tough to get an 18-year-old not to want to eat burgers and pasta and drink Mountain Dew. This is what they're craving, and it takes a lot of work to convince younger people who are going to have a better chance of being healthy as they're older when they start at that young age.
Yeah, I agree. And I think that's why, our business, Vitality Collective, same with you, we start seeing people really in sort of mid-age. Mm-hmm. Maybe 35 is sort of the youngest people that we start seeing who are starting to think about that long-term projection. I think that time period where your back starts aching just from getting out of bed, and you start getting in touch with your mortality a little bit more. I think the earlier we can push that, the better. But that midlife period, I think, is where we see the most interest in this, and really, really pushing people in this direction of early intervention.
I think so. And I think it's also another push for doing biomarkers, because when you take younger people and you discuss these concepts, being older is far away on the horizon for them. They can't even picture it. But if you show them the biomarker results, it moves from the abstract concept to something real on paper that you can show them. Look, your neurons are under stress. Let's track these things. Let me get you on a better way of eating and more exercise.
Yeah, I think that's a great way to then segue into the lifestyle factors that we can put in place to reduce these risk factors. Let's start with that sleep and really sort of dig into the behaviors around sleep. And, we've talked a lot about sleep apnea, people with sleep conditions. What should people be looking at with their sleep to be able to really get through these sleep disorders and reduce their risk?
So whatever you can do to increase your sleep to at least 7 hours a night is helpful. And that means less caffeine later in the day, less stimulation, screens, music, lights. Start turning down your lights after dinner. Let your brain prepare to shut down. There was a study that showed that people with 5 hours or less of sleep a night have a double increase in Alzheimer's dementia.
Wow. That's a pretty profound figure just from getting a couple of hours of extra sleep.
Yes, and also for those people that get 7 or more hours of sleep and they wake feeling unrefreshed, I will suggest a sleep study because there are so many people with undiagnosed sleep disorders. One of the things that makes me crazy is there's a lot of assumption out there where you only have sleep apnea if, and I should say obstructive sleep apnea. There's another called central, which is more because of a issue with the brain. But people with obstructive sleep apnea are all obese. I have severe sleep apnea, obstructive sleep apnea. And in one of my polysomnograms, I stopped breathing 80 times an hour without a mask. It has mostly to do with the anatomy of your jaw and your mouth and your tongue falling back and blocking your airway. Certainly obesity plays a role as well, but a lot of it is anatomy. For example, I was having a conversation with someone pouring my wine the other night, and she's petite, and she told me that she went to several doctors complaining of chronic fatigue. She got sent for a polysomnogram, and she has severe obstructive sleep apnea. You couldn't see her if she turned sideways, and she's got a condition too. So we just need to be mindful of the fact that if somebody is waking unrefreshed, to think about the possibility of sleep apnea as a cause. So we might not be talking about insufficient sleep, but we're talking about fragmented sleep.
Yeah, really interesting point there, where people think they're getting enough sleep. We talk a lot about the sleep opportunity, and people think that if they're in bed for 8 hours, they're asleep for 8 hours. The sleep opportunity is, if you give yourself 8 hours, that's the opportunity, but it takes you X amount of time to fall asleep, your wake ups during the night. And so you can actually find that your sleep number is pretty impacted.
Yeah. Whatever you can do to get a better sleep. I think, we all live in a stressful society and we're busy doing things. And, I've been guilty of this in the past as well. And I'm trying to improve that for myself, is that when I'm done with all my work, I've got this bit of nighttime. I want to enjoy a show or reading something. And if we're going to pinch anything, we're going to pinch our sleep time because we're trying to have that little bit of time at night. But this is something we have to work on because, evolution made us hold on to the need for sleep for a reason. Evolution gets rid of stuff it doesn't need. And so, keep your bedroom dark. I wear foam earplugs every night so that noises in the street won't wake me up. And keep the bedroom cold. Your body needs to drop 2 to 3 degrees Fahrenheit to sleep well.
Yeah, and one of the other factors that we see a lot, and we were certainly very guilty of, is pets in the bedroom. Whether it's the dog sleeping on the bed, the cat can get in and out of the bedroom. All of this disrupts your sleep. So these are some of the big changes that we've made. Exactly that. It's in your sleep hygiene. How are you preparing for bed? Do you keep your phone by your bed? Are you watching the television in bed? All of these things that can create these micro wake-ups and just pull you out of that deep sleep. We saw it from a performance standpoint at the very top end of sport on how sleep impacted performance. But then at this end, we really see it being a driver further down the spectrum into these states.
Agreed. I can see how that happens with your athletes. When I have a fragmented night of sleep because I tore my mask off in the middle of the night, when I go running up the mountain, I'm dog tired. I'm struggling. When I've slept well, I can run up there well without much limitation.
And some of the other factors, I think, you mentioned caffeine, but alcohol was one of the biggest ones for me. It's actually the reason I stopped drinking a couple of years ago, was essentially because of the impact it was having on my sleep. So I think really important there to look at how close to bed you're having alcohol, which initially will be a depressant and sort of help you go to sleep. But then as it starts being digested, will become a stimulant and actually wake you up during the night.
Sure. And I think what might be happening is that you've anesthetized your brain, and when it's metabolized and the alcohol level drops, your brain wakes up. If you have ApoE4 and you drink several drinks per week, your risk of dementia goes up further than having ApoE4 and not drinking any alcohol.
Well, so just on its own, it's a risk factor.
Yes. More so in people who have ApoE4, but this is consistent along the line with all those other risk factors like dyslipidemia and metabolic problems like type 2 diabetes.
I think it's really important to touch on as well the stress reduction piece you mentioned. We're in a stressful world. I think stress is one of the biggest reasons that people don't sleep. Are there things that you recommend to people to help reduce stress?
Well, you're good to bring up the stress, because stress and hypercortisolemia affect your brain as well. Stress, number one, blocks melatonin, and that's one of the reasons why it impairs your sleep. But people who have a persistent hypercortisolemia, their cortisol level is chronically elevated because of stress, have smaller brains on imaging. What I advise for stress is meditation and exercise. And if the stress level is just bonkers high, and the obvious low-hanging fruit like meditation and exercise aren't helping, then I advise psychotherapy.
Yeah, I think, having incorporated all of those into my life, I think that, again, in the spirit of being proactive, the psychotherapy before there's an emergency, before you're losing sleep because of stress, just in that maintenance, for me has been absolutely profound. And then adding things like meditation, at least a few times a week. When we get busy, it's when we need it the most, but it's when it's most difficult to take that time. I think with meditation, people think that you've got to be wearing a robe, sitting on a cushion with incense for a couple of hours. But 5 minutes is all you need to get the benefits. In fact, the SEALs just use a breathing technique they call box breathing, where you inhale for 4 seconds, hold for 4, exhale for 4, and then hold for 4. And they just do that for 4 minutes a day. It's not out there. It's not this strange practice that they have. It's literally just that controlled breathing, 4 minutes a day. And they've shown big reductions in stress, and they'll use it acutely when they get into a conflict situation, and they'll use it day to day to just generally bring stress down.
And you do your meditation in the morning?
Yeah, I typically do in the morning. Wake up and go right out and meditate. Yeah, at least 5 minutes. Yeah, we just go out on the little balcony here, and we've got all our plants around, and we've got a nice little environment set up where we sit, and it's nice and peaceful. So yeah, it's great, and we see the sunrise, from the balcony as well. So that's always a special time.
Sounds like a good plan.
Yeah, it's been great for us, and it really is profound, the impact. Now, something that I think people may not know about, and this was certainly new to me, was the impact of hearing loss on cognition. Can you talk to us a little bit about that?
I don't think it's been confidently elucidated what about hearing loss impacts your risk of cognitive problems. There is a theory that it's less sensory input into your brain. So, let's use an associated example. When you have an elderly person who has significant cognitive decline, you put them in a nursing home where they have no social interaction. They're basically just sitting there. They're probably going to decline rapidly. They're just not getting any stimulation. So is it that? Is it less sensory input? Or is it that there are changes going on in the brain that also affect your hearing? But in any case, what I suggest to people is if you're having hearing loss, intervene early and get hearing aids. You know, there's a lot of pushback from some people about wearing hearing aids, you know, even though they're smaller now. And some people, I don't even see it until I get closer on my examination. But I think there's a lot of thought from aging patients about, oh, that makes me look old. Now I'm going to be old that I'm putting this hearing aid in my ear. But lately I've been telling them, look, hearing loss impacts your risk of cognitive decline. Just start early and put it in your ear.
Yeah, it's a great message. And I really love this rounded approach that you're taking. Is there anything that we haven't discussed so far that you think is important for us to bring up around brain health?
I think, as you do, that the things that take a lot of work are the most important. And those things are, of course, exercise, good sleep, avoid overnutrition. Eat when you're hungry. Don't eat when you're not hungry. Don't eat just to eat. You got to keep yourself in energy balance. Reducing stress. But there are some supplements which might be very helpful in the right people. We don't want to over supplement, but we want to keep people topped up so they don't have deficiency.
And what would be some of those key supplements that you consider?
So one thing I check on every patient is the homocysteine level. Higher homocysteine level is associated with vascular disease, atherosclerosis, and elevated homocysteine also increases the risk of the increased tau and neurofibrillary tangles. So homocysteine impairs the production of NO, nitric oxide. Nitric oxide is important for vascular health because it relaxes the muscle around the vessel, allowing it to widen and send more blood flow through. That would be important for your brain. And it supposedly reduces inflammation within the artery and reduces the tendency to clot. So when I think of elevated homocysteine level, I think of impaired methylation. So methylation is the adding of a methyl group, which is one carbon and three hydrogens, CH3, to many different molecules in the body, including DNA. DNA requires methylation to switch on and off genes. But methylation converts homocysteine to methionine, to S-adenosylmethionine. These are carbon donors, methyl group donors. So there is a gene called MTHFR, which allows you to methylate. And many people are deficient in this gene. They have a mutated form, which causes insufficient methylation. And so if I see a high homocysteine level, I am going to offer methylated vitamins. These are already methylated B vitamins like methylfolate and methyl B12.
Is it just the B vitamins that you would recommend? Are there other vitamins that would need to be methylated, for example, like vitamin D or C or anything else that you're taking?
No. I mean, I think chiefly about B vitamins, and they're readily available in supplements that are high quality with good quality controls, like Thorne and Life Extension and Jarrow, Jarrow. Folate and vitamin B12 are the two vitamins which require methylation in that cycle where homocysteine is converted to methionine and then S-adenosylmethionine. And so the question I ask myself is elevated homocysteine a sign of other things, and it's these other things that are causing the increased risk of Alzheimer's dementia, or is it the elevated homocysteine itself, or both? It may be both.
Yeah, and I think, from a practical standpoint, and that's sort of what we're all about, is what do I do about it? I don't think it matters, right? I think if we can impact both, then that's what we do. And, it's just really important to have actionable steps that I can go out tomorrow and do. And this is one of them. For example, you and I talked about, I have that mutation in the MTHFR gene. And so I've started taking methylated vitamins. So these are really practical steps that people can take to help offset these risk factors.
So yeah, think of these methylated B vitamins as something that supercharges your methyl recycling system. And so what is my goal for a homocysteine level? I like it less than 8. I saw a patient just last week, he had a level of 16. That's pretty high. So I put him on methylated B vitamins, and I'm going to recheck him in a few months, and hopefully we'll get his level down to a safe place.
That's fantastic. And are there any other supplements outside of the vitamins that you'd recommend?
Sure. Well, DHA is incorporated into neuron membranes. And a lot of us are not eating enough oily fish to replete our DHA level. I grew up in the Midwest in the 60s and 70s, and we didn't have any fresh fish there. At that time, it was very expensive to fly in fish from the sea to the Midwest. So I never grew up with a culture of fish. It's only as an adult now that I'm eating it. So before I offer an omega-3 supplement, I will check the omega-3 level. The VitaCog study showed that you improve cognition if there was a deficiency and then you supplement it. If somebody was already topped up, supplementing is not likely to add benefit. So, for example, and there's many companies that do this, but Quest Diagnostics has something called Omega Check. And you want to assess the amount of omega-3, DHA and EPA on the red blood cell membrane. That's more of a stable biomarker that doesn't fluctuate as much when you eat.
Yeah, similar to HbA1c for blood sugar, right?
Correct. Or even using, instead of testing the blood level of magnesium, you check the red blood cell magnesium or the red blood cell folate, because those are more stable. If you are deficient in folate and you eat one meal and then you check the person's blood, you might see a sudden rise in the folate, leading you to believe, oh, this person's folate is topped up, where in fact the blood level might be fine at that moment, but their total body folate might be deficient.
With inflammation, you've mentioned being such a factor in both the vascular system as well as in the brain. Is there anything that people can do or take to reduce inflammation?
Well, one of the things is to keep your visceral body fat low, and also to keep yourself in energy balance. You know, I see people filling up their shopping carts with bad stuff every time I go out to the market, and I'm thinking to myself, how do you put all that stuff in your body? You have to be more mindful about what you eat. There is something that rises, as I said, in your blood when you exercise called clotho. And there are multiple companies now trying to produce a product that is clotho in an injectable form. And clotho is neuroprotective as well as keeping your body healthy in general. When you block the gene for clotho in mice, they become ill-appearing and old very quickly. They have a lifespan of only 3 years, so you can quickly assess the effects of your interventions.
What exactly is clotho?
Clotho is a gene that's produced by the kidneys, and it helps you to dump excessive phosphate, and it keeps the kidneys healthy in general. But it's also produced within the brain in the choroid plexus. And clotho is strongly associated with a reduce of cognitive decline. And it does so through various ways. There's something called the NRF2 pathway that is anti-inflammatory, antioxidant, so it switches that on. It helps to reduce the impact of the NF-kappa beta pathway, which is pro-inflammatory. And it also modulates transforming growth factor beta. Here's another example of a molecule that has multiple effects and may be friend and foe. Transforming growth factor beta, TGF beta. It has, at some level, anti-inflammatory effects. But if it's hyperactive, it can lead to fibrosis. For example, in the body, it can lead to pulmonary fibrosis, liver fibrosis, kidney fibrosis. So I think that's what makes it hard for making drugs to combat dementia, because if you have a drug that shuts down a molecule completely, maybe you've eliminated the beneficial effects of that molecule. So it's a matter of turning the volume knob just the right way. And I think it's complicated. That's why I think, as you've said, the approach to preventing cognitive decline would be, at least in 2025, our best bet. I think, the things that you do to stave off Alzheimer's dementia are good for your body as a whole. So just keeping that simple. If I may, before we leave the topic of clotho, I wanted to bring up some other things that raise clotho apart from exercise. It's a long list. It's berberine, metformin, curcumin. It is drugs like Ozempic, statins, certain antihypertensive drugs like losartan or valsartan in that class, the ARBs. So curcumin is something of recent interest that may reduce cognitive decline. But you can't just take regular curcumin for it to impact your brain. There is a proprietary product called Theracurmin. It's a nanoparticle, and it may be associated with a slower cognitive decline. It certainly doesn't appear that it would hurt anybody. So it's one of those things that maybe not as effective as exercise and so on, but throwing that in there might be helpful to some extent, especially to those people that are at the higher risk of having dementia, the ApoE4s, the people with type 2 diabetes mellitus and so on.
Yeah, I think you're absolutely right there. Throwing it into that supplement mix, I think, is additive for sure. But, I think to put all of that in perspective, the supplements are exactly that. They supplement all of the big things that you're doing. I think, number one, know your risks. Number two, do the hard work, the exercise, the diet, the sleep, all of these factors that you've alluded to. Then we start looking at what are the marginal gains that we can make. So the supplements then to sort of fill in the gap. That for me is really the sort of order that those three should go in. I just think you've listed so many factors that are under our control. And for me, that's a super hopeful message, because I think it's probably the condition people fear the most, cognitive decline. It robs you of so much. I just think that people hearing that this is largely under their control and there is so much agency they have in the decisions that we make every day, the work that we do versus the work that's done to us, to really dial this in. It's really, really hopeful for me. So I just appreciate your message today so much. Dennis, thank you so much. Again, this was just such incredible content, so hopeful. And we'll summarize all of this in the show notes. But before we sign off, just real quick, you've recently moved your practice into Montecito. Are you currently accepting patients?
I am. I offer a meet and greet just to say hello and see if it's a good fit. And although I do one-off consultations, I hope to develop a membership practice where my patients are with me over the long term, and I can do general internal medicine and talk about longevity.
That's amazing. Just from a personal standpoint, the work that we've done together on different clients and patients, there hasn't been someone that I've worked with in this field who is as well-rounded and progressive as you, and stays as current. And so, anybody lucky enough to get to be a patient of yours, that they're going to get the latest in care. It really is so important to find a practitioner with a mindset of proactive care versus just reactive, waiting for you to get sick and giving you medicine, not staying current on the latest diagnostics. So I really can't speak highly enough of your practice and how you practice medicine.
What a compliment. Thank you.
And where can people find you?
It is www.DennisHughesMD.com.
Well, Dennis, again, thank you so much for joining us. We really appreciate you. And there's just a trove of knowledge here. So thank you again.
Thanks for having me. It was fun.
Thank you for tuning in to this episode of the Vitality Collective podcast. Today we learned 3 critical ways to protect your brain health. Number 1, prioritize deep, restorative sleep. Number 2, incorporate regular exercise to boost neuroprotective factors. And number 3, stay proactive about testing biomarkers for personalized interventions. Remember, your daily choices play a powerful role in shaping your cognitive future. Until next time, stay vital. Just a quick reminder before we sign off. The information provided in this podcast is for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.